Hello, my dear doctor. I'd like to talk on a very important topic, that is congenital adrenal hyperplasia. So let's talk on them. Just follow me what is written on your notes. Congenital adrenal hyperplasia overview. Group of autosomal recessive disorder affect the adrenal steroid biosynthesis, circle the steroid biosynthesis, circle the autosomal recessive disorder. In response to the resultant low cortisol levels, the anterior pituitary secretes the high levels of ACTH. Circle the low cortisol, circle the high ACTH. ACTH stimulates the production of adrenal androgens that may virilize an female infant. The causes are include, there is a 21 hydroxylase enzyme deficiency. So 90% cases, circle the 21 hydroxylase enzyme, 11 beta hydroxylase enzyme deficiency 5%, and 17 hydroxylase enzyme deficiency, which is very, very rare. I would like to read more further from your notes, my dear. Congenital adrenal hyperplasia features. It includes the 21 hydroxylase deficiency in features. Virilization of the female genital, circle the virilization. Precocious puberty in males, circle the precocious puberty. In case of males, 60 to 70% cases, patients have a salt-losing crisis at 1 to 3 weeks of age. Circle the salt-losing crisis at the age of 1 to 3 weeks. 11 beta hydroxylase deficiency features. It includes the virilization of the female genitalia, circle the virilization. Circle 11, precocious puberty in males, similar presentation like the 21 hydroxylase enzyme deficiency, but it has the hypertension and hypokalemia. Circle the hypertension, circle hypokalemia. 17 hydroxylase enzyme deficiency, which is very, very rare. It includes non-virilizing in females. Circle the non-virilization, intersex in boys, but it has the hypertension. Circle the hypertension. So what we have observed basically, we have seen there are three important causes of congenital adrenal hyperplasia. It includes 21, just to remember, next to the 11, then the 17. 21, 11, 17. Say with me, 21, 11, and 17. But the 21 not associated with the hypertension. In contrast, yes, once again, the 11 and 17, just remember my dear, 11 and 17 is associated with the hypertension. Yes, 17, just forget it. 11 at least that you need to remember is an hypertension. We'll talk more further. Yes, my dear doctor, before going to the congenital adrenal hyperplasia, I'd like to talk on a bit of important topic, also the causes of amenorrhea. So just follow me what is written on your notes. Causes of amenorrhea, it is written that the physiological, there is a pregnancy, of course. Pregnancy is the most common cause of amenorrhea. Systemic disease, the celiac disease, circle the celiac disease. Weight loss, anorexia nervosa, excessive stress. Hypopituitarism. Next is the prolactinoma, primary ovarian failure, congenital adrenal hyperplasia. PCOS is a polycystic ovarian syndrome, and Cushing syndrome, androgen secreting adrenal tumor, and adenoblastoma, there is an androgen secreting ovarian tumor. So this is a very important causes of amenorrhea that we need to know the causes of amenorrhea before going to the congenital adrenal hyperplasia. Yes, my dear doctor, I'd like to talk on also another important topic. There is a differential diagnosis of mild 21 hydroxylase deficiency. It includes the polycystic ovarian syndrome like the PCOS, then androgen secreting adrenal tumor like we call the ASATH, and adenoblastoma is nothing but the androgen secreting ovarian tumor that we call the ASOT, and next is the Cushing syndrome is the CS. Yes, my dear doctor, I'd like to give an important box, right, the SS box, before going to the full discussions of the congenital adrenal hyperplasia. So very importantly, right, I will discuss about the cholesterol synthesis here, but beforehand, I'd like to talk on Here the important SS box, and I'll write very shortly, that will be really helpful. Right, the causes of amenorrhea. I'm writing the amenorrhea. Yes. Of course, the pregnancy is the most common, no doubt about it. So the first bundle pack starts with the pregnancy. Yes. And along with that, right, that we can, along with the pregnancy, that we can talk about the primary ovarian failure, primary ovarian failure. So ovary is controlled by, you know about the pituitary gland. So of course the hypopituitarism. So you can write the hypopituitarism along with the prolactinoma, the bundle pack. So yes, this is the bundle packs, and which is controlled by the another bundle pack, the above the pituitary gland, that is the hypothalamus. So we can write the hypothalamus is nothing but the some of the systemic disease like the celiac disease plus extreme weight loss plus anorexia nervosa and the stress, excessive stress. So this is the bundle pack, along with, of course, the congenital adrenal hyperplasia, this bundle pack. And other four important causes are basically the mild 21 hydroxylase enzyme deficiency. These are nothing but, we can write the androgen secreting ovarian tumor, SOT, androgen secreting adrenal tumor, SOT, Cushing syndrome, plus precocious bundle pack. So this is the very important box, my dear, that you need to know the causes of amenorrhea. Another important box that I'd like to write it down here before going to the discussions of congenital adrenal hyperplasia. So what is that? So causes of Hirsutism and Virilization. Hirsutism and Virilization box. So yes, once again, the bundle packs that we have write down the congenital adrenal hyperplasia plus the precocious is the second cause plus, of course, the SOT plus SOT and the Cushing syndrome, this bundle pack. Along with some of the drugs, anabolic drugs, abuse, they can cause. The drugs are dioxide, minoxidil, yes. Then the phenytoin, cyclosporin, androgens. Phenytoin, cyclosporin, and androgens. So this is another important box that we need to know about them all them together. Yes, my dear doctor, I'd like to talk more from your notes, what is written. Just follow me. Congenital adrenal hyperplasia may be caused by a number of enzyme defects in the biosynthetic pathway for the steroid hormone synthesis within the adrenal gland. The deficiencies are inherited as an autosomal recessive trait, circular recessive. The most common abnormality by far is 21 hydroxylase enzyme deficiency, circular 21, the gene for which on chromosome number 6, circular 6. The enzyme is responsible for conversion of 17-hydroxyprogesterone to cortisol. What is that? The 21-hydroxylase enzyme is responsible for conversion of the 17-hydroxyprogesterone to cortisol. So if you see that 21-hydroxylase enzyme is responsible for 17-hydroxyprogesterone to convert into the 11-deoxycortisol, but directly we can see the cortisol. So yes, 17-hydroxyprogesterone up to cortisol, we can say. 21-hydroxylase deficiency leads to elevated, of course, the 17-hydroxyprogesterone, circle the 17-hydroxyprogesterone, which is metabolized to adrenal androgens. These ketosteroids are found in high concentration in the urine, and the patients are cortisol deficient. Some may also have aldosterone deficiency. Patients with severe 21-hydroxylase enzyme deficiency present in infancy, circle the infancy, vomiting and failure to thrive. Circle vomiting, circle failure to thrive in infancy. Ambiguous genitals are common, circle the ambiguous genitals. Males have the hypospadias, circle the males are hypospadias. Females have the fusion of labia, circle the fusion of labia. Males with mild deficiency may present with the precocious puberty, and females with primary amenorrhea, hirsutism and virilism. Circle the males, circle precocious puberty. Females, primary amenorrhea, circle hirsutism and virilism. Hirsutism occurring before the menarche, circle hirsutism before menarche. Menarche means the starting of menstrual cycle. Is suggestive of congenital adrenal hyperplasia. Hirsutism before menarche, circle hirsutism before menarche, circle is congenital adrenal hyperplasia. Lack of cortisol is responsible for a high ACTH level, which continue to drive the biosynthetic pathways. Lab investigations reveal an elevated plasma 17-hydroxyprogesterone and ACTH. Urinary pregnanatriol level is also elevated. Circle the urinary pregnanatriol. Treatment is hydrocortisone replacement, circle the hydrocortisone. The dose is similar to that in Addison's disease. The therapeutic response is judged by suppression of the urinary pregnanatriol level to the upper limit of the normal. Considerable care should be taken not to give a very high dose of hydrocortisone, as this may stunt the growth. Patients with aldosterone deficiency are judged by elevated of renin level and postural hypertension should receive fludrocortisone, circle the fludrocortisone. Differentiation from an adrenal androgen secreting tumor, like the androgen secreting tumor, adrenal is the SHART, we can say, is possible by performing a low dose dexamethasone suppression test, LD-DST, which will reduce the urinary pregnanatriol level in congenital adrenal hyperplasia. So yes, urinary pregnant level will be reduced, but not in adrenal androgen secreting tumor. The differentiation from PCOS is possible by measuring the 17-hydroxyprogesterone levels and dihydroepiandrosterone dione sulfate, both of which are high in congenital adrenal hyperplasia. Alternatively, a synoctane test may be performed, which is associated with the normal cortisol response in PCOS, but not in congenital adrenal hyperplasia. Some of the differential diagnosis of hirsutism and virilism that we have already written, you see the hirsutism and virilism, it includes that, just follow me, congenital adrenal hyperplasia, polycystic ovarian syndrome, androgen secreting adrenal tumor, Cushing syndrome. Adenoblastoma is nothing but the androgen secreting ovarian tumor, that is the SOT, and anabolic drug abuse. Some of the differential important points of the primary PCOS, means the polycystic ovarian syndrome, it says that the rarely presents with the amenorrhea. Androgen secreting tumors of the ovary are malignant, means the SOT are malignant and wouldn't have such a long history. Furthermore, they usually present at an older age, means the androgen secreting ovarian tumor, SOT. Androgen secreting adrenal tumors are also usually malignant and usually also produce cortisol. Therefore, affected females are virilized and have the features of Cushing syndrome. Hello, my dear doctor. I'd like to discuss the congenital adrenal hyperplasia onto the board. Before going to the congenital adrenal hyperplasia, my dear, we need to be very, very vigilant to know the steroid biosynthesis and what happened in this biosynthetic process. So, my dear, very starting with the cholesterol, right? The cholesterol biosynthetic process. So, cholesterol, that I just made it very simplified ways of biosynthetic process of different cortisol, aldosterone, and also the testosterone. So we know about the cortisol, right? We know about the cortisol. That is a glucocorticosteroids, right? Make a start. We know the aldosterone. I put the aldosterone. This is the mineralocorticosteroids. And androgens are the, you see, the androgens. That is the testosterone. So these are the three important things that we need to know the biosynthesis, how it is happening. So let me start by, first of all, we know about the cortisol, the starch that leads to the pregnenolone. I don't write down the enzymes, different enzymes are responsible. You don't need to know them very, very well. You just need to know the way that I have written here. Yes, my dear doctor, so cholesterol that turned into the pregnenolone. So this pregnenolone, just you made it pregnenolone. Next, pregnenolone changing to the progesterone. So once again, cholesterol, pregnenolone, progesterone. Cholesterol, pregnenolone, progesterone. This pregnenolone, you see the 17-hydroxy tagged with it. That is called the 17-hydroxy pregnenolone. Same thing, this is also changing to 17-hydroxy progesterone. So progesterone also can be changed into 17-hydroxy progesterone. So my dear, forget all them together now. So we need this 17-hydroxy progesterone. What do you need? 17-hydroxy progesterone. 17-hydroxy progesterone, you see? Because we have written here the 21-hydroxylase enzyme, this is responsible for changing that 17-hydroxy progesterone to 11-deoxycortisol, which is further by the 11-beta-hydroxylase enzyme leading to the cortisol level. My dear, listen very carefully. We already learned that 21-hydroxylase enzyme deficiency is the most common cause of congenital adrenal hyperplasia. Next to them, yes, there is 11-beta-hydroxylase. Another one is the 17-alpha-hydroxylase enzyme deficiency. So I can make a box here and box here. Just remember this one. So what I say, this is very important, my dear. So starting with the 17-hydroxyprogesterone that leads to, by the 21, with the help of 21-hydroxylase enzyme that turn into 11-deoxycortisol, that turn into the cortisol, forget it, deoxycortisol, here's the cortisol, then cortisol turn into the aldosterone by the help of 11-hydroxylase enzyme. So my dear, what I'm saying, yes, among them, just forget now the cholesterol, that the pregnenolone, then the progesterone, once again 17-hydroxypregnenolone, 17-hydroxyprogesterone. Now forget, my dear, just remember 17-hydroxyprogesterone. What I said? 17-hydroxyprogesterone. Yes, this 17-hydroxyprogesterone is changed to the cortisol, changed to cortisol, yes, cortisol, then turn into the aldosterone. So what I'm saying, my dear, this is very important that you need to remember this important information. So what I'm saying, 17-hydroxyprogesterone turn into cortisol, aldosterone. Very three simple talk that we need to remember. So yes, the cortisol. Next is the aldosterone. Now let's talk, right, the 17-hydroxyprogesterone, this is the 17-hydroxypregnenolone, then dihydroepiandrosterone done by the help of 17-alpha hydroxylase, dihydroepiandrosterone done, then the androsterone done, and testosterone. These are nothing but the androgens. These are nothing but the androgens. We call them the androgens. And these oxosteroids are, they comes up with the urine, so we call the urinary pregnanatriol. Yes. This is also another important information. Now let's talk on the congenital adrenal hyperplasia. The most common is the 21 hydroxylase enzyme deficiency. Feel it now. If the congenital adrenal hyperplasia deficiency, if the enzyme is deficiency, so what happened? So there will be no 17-hydroxyprogesterone will change to cortisol. So the blood level of the 17-hydroxyprogesterone level will be high. We can write. So the 17-hydroxyprogesterone will be high. This leads to the 17-hydroxypregnenolone will be high. This leads to the dihydroepiandrostenediones will be high. This leads to the androstenedione will be high. This leads to the testosterone will be high. This leads to the oxosteroids that comes up as a urinary pregnant erythritol will be high. So my dear, once again I'm saying, right, that if the 21-hydroxyl enzyme deficiency, so 17-hydroxyprogesterone will be high, 17-hydroxypregnenolone will be high, dihydroepiandrostenedione will be high, because this is diverting to produce the dihydroepiandrostenedione, then androstenedione, then testosterone, then oxosteroids comes up as a urinary pregnant erythritol will be high. This is the number one point that we need to remember. Forget all them. Yes, the 21-hydroxyl enzyme deficiency leads to increased 17-hydroxyprogesterone level will be high. Just remember 17-hydroxyprogesterone, I call the 17-HOP, HOP, will be high. That leads to, yes, all the androgens will be high and urinary pregnant erythritol will be high. Just remember the single pathophysiology and pathogenesis that we are getting the biochemical abnormalities. First of all, right, this is the first thing we can write here. And second talk, right, you see 17-hydroxyprogesterone is not converting to cortisol. So whenever the cortisol will be low, yes, this leads to the high ACTH level, of course. And this ACTH, adrenocorticotropic hormone, is responsible for adrenal hyperplasia. That's why this is called the congenital adrenal hyperplasia. Congenital autosomal recessive adrenal hyperplasia. Why? Once again, because of low cortisol level leads to the ACTH is high, that leads to the adrenal hyperplasia. Same thing, cortisol is low, this leads to the low aldosterone level. So we can get this category of the findings all together whenever the patients have the congenital adrenal hyperplasia due to 21-hydroxylase enzyme deficiency. Yes, my dear doctor, I'd like to talk on further a little bit. And I'm also writing, just follow me, and you also make your own notes, that will be really helpful. So if I'm writing here now, forget it now. So let's start the congenital adrenal hyperplasia, which is congenital, means the autosomal recessive, all right, and gene abnormality, that is the chromosome number 6. And the most common enzyme deficiency, of course, we are talking about the 21-hydroxylase enzyme deficiency. Right? The enzyme is responsible for 17-hydroxyprogesterone to convert to cortisol. So what will be happen? So just make a box. So this 21-hydroxylase enzyme deficiency leads to the increased 17-hydroxyprogesterone. Hope. Just write it down, 17-hydroxyprogesterone, which leads to, the number one point, the increased 17-hydroxyprogesterone. That leads to, you see, all the androgens will be high. 17-hydroxypregnenolone will be high, androstenedione, testosterone, all androgens will be high. So we can write that all androgens will be high. So number 2, we can write the findings are we can write increase dihydroepiandrosterone, increase androstenedione, increase testosterone. The way I'm writing, just follow me. And these comes up as a urinary pregnanediol. I just write down the UP, that will be helpful, UP, and that will be high. Second important point, my dear, whenever, yes, I said that the 20 hydroxyl enzymes, so cortisol will be low. So yes, low cortisol, that leads to, yes, raised ACTH. And low cortisol also, once again, that leads to low aldosterone. And low aldosterone, once again, can increase the renin as well. This is the important lab findings that we need to know, my dear. Now we can write in another box for the congenital adrenal hyperplasia. What is that? In infancy, hyperplasia, infancy, they can present with the vomiting and failure to thrive. Right? Failure to thrive. Ambiguous genitals. Genitals are common. For case of male, that leads to the hypospadias. For females, usually the fusion of labia. Hypospadias and fusion of labia. Male with mild deficiency, male persons with a mild deficiency, they can come with a precocious puberty. But in contrast, the females, yes, the primary amenorrhea plus Hirsutism and virilism combinations. One of the important things, right? Hirsutism before menarche. Hirsutism before menarche equal to congenital adrenal hyperplasia is another important box. Now let's talk on the treatment box. This is box, treatment box. Here's very close to the treatment of Addison's disease. The hydrocortisone replacement, the congenital adrenal hyperplasia treatment. Number 1, hydrocortisone. Yes, replacement. Hydrocortisone replacement. Yes, my dear doctor, hydrocortisone replacement, what I'm talking? Yes, dose similar to Addison's disease. Addison's disease. But the most important thing, the therapeutic response, let's write it down, the therapeutic response is by suppression of the urinary pregnanediol levels, to upper third of the normal. So this is the therapeutic response, and considerable care. Very high dose hydrocortisone should not be given at the early because of the stunting growth. And number 2, the patient with aldosterone deficiency guided by increased renin level, and plus postural hypotension, should receive the fludrocortisone. And those should be adequate enough to suppress the ACTH level and these dose adequate enough to suppress the ACTH level. So this is very important box, my dear doctor. You need to know very, very well. Another important box that I'd like to give, the congenital adrenal hyperplasia. Already we learned about 21 hydroxylase enzyme deficiency, another one 11, and 11 was the 17. So my dear, what I'm saying, my dear, 21 hydroxylase enzyme deficiency. So this is very important. So you see the low cortisol, low aldosterone, so there is a chance of hypotension. So we can write the hypotension means BP will be low. In contrast, 11 hydroxylase, you see, if I make the 11 just an H for hypertension. So both the 17 and 11 I'm just making. In contrast, the 21 hydroxyl enzyme deficiency is hypotension. This is another box that we need to remember altogether. What I'm saying is the congenital adrenal hyperplasia caused by 21 hydroxylase enzyme deficiency and also 11 and 17. I just made the 11 is an H for hypertension, my dear, must remember. H for hypertension. 11 beta hydroxyl enzyme deficiency is responsible for hypertension, and 17 also hypertension. Just forget the 17. Must remember the 11, hypertension. Forget now 11 and 17. But the 21, what is the most common form? That is the 21 hydroxyl enzyme deficiency can be hypotension. But H means the 11 is the hypertension. That is the talk that I would like to say. My dear, I'd like to summarize all them together here. The first box here, the SS box, I start from the cholesterol biosynthesis leading to all the pathogenesis. Yes. All together. So I'd like to talk on now further, right? The congenital adrenal hyperplasia. Right? You see that this is a box, congenital adrenal hyperplasia. Yes. This is autosomal recessive disorder, the chromosome number 6, the most common, the 21 hydroxylase enzyme deficiency. I'd like to start now from the first box. My dear, just forget all them together. Just remember the cholesterol, pregnenolone, and then progesterone, 17 pregnenolone. 17 hydroxy progesterone, that leads to the cortisol, then leads to the aldosterone. Very simple. Cholesterol, pregnenolone, progesterone. 17 hydroxy pregnenolone, 17 hydroxy progesterone leads to, once again, yes, my dear, that we can remember the cortisol. You see the cortisol, pregnenolone, and then 17 hydroxy progesterone, and then leads to the cortisol and then aldosterone. Same thing is diverting the 17 hydroxy pregnenolone, that dihydroepiandrosterone down, and then testosterone, oxysteroids that comes up in a urine, that is the urine pregnaneditriol. So once again, the biosynthetic cholesterol, pregnenolone, progesterone. Pregnenolone turned to 17 hydroxy pregnenolone, 17-hydroxyprogesterone, 17-hydroxyprogesterone. Forget now all them together. 17-hydroxyprogesterone, HOP, HOP, 17-hydroxyprogesterone, HOP. These turn to, yes, of course, the cortisol, then aldosterone. 17-hydroxyprogesterone, cortisol, aldosterone. And then 17-hydroxypregnenolone turn to dihydroepiandrosterone down, epiandrosterone down, or maybe androsterone down, and last to testosterone, then comes to the urine as an oxosteroids, yes, as an urinary pregnant. So my dear, I would like to talk on now the congenital adrenal hyperplasia in 21-hydroxylase enzyme deficiency. What happened? If the 21-hydroxylase enzyme deficiency that leads to, yes, the 17-hydroxyprogesterone will be high, 17-hydroxypregnenolone will be high, dihydroxyepiandrosterone down will be high, and androsterone down will be high, and then testosterone will be high. Means they come up with the urinary pregnant will be high. So my dear, now forget all them together. I'm saying the single talk that we need to remember from all the discussion back onto my board. What is that? Now I'm talking the mystery here. My dear, whenever we discuss, right, we'll see in the data and the lab findings, the congenital adrenal hyperplasia, what I'm saying, will directly look into the up. This up is the most important thing that we must remember. Urinary pregnant endometrial. Congenital adrenal hyperplasia is an up, just remember. Urinary pregnant endometrial. Once again, congenital adrenal hyperplasia is increased urinary pregnant endometrial up. CAH equal to up, CAH up. So we can write the cup, all right? So we can write a box. Yeah. Is a cup. C for congenital adrenal hyperplasia, UP4, urinary pregnant. Urinary pregnant, all right? So you see the pregnant. Yes, so this is nothing but the up. This is congenital adrenal hyperplasia. Of course, the 17 HOPE, I put the name here, the HOPE, hydroxyprogesterone, and of course the dihydroepiandrosterone, and then androsterone and testosterone, all the androgens, and also the low cortisol, low aldosterone. Low cortisol leads to the raised ACTH and raised renin level. We know the data here. So once again, the congenital adrenal hyperplasia 21-hydroxylase enzyme deficiency leads to 17-hydroxyprogesterone will be high, 17-hydroxypregnenolone will be high, then dihydroepiandrosterone down, androsterone down, and testosterone will be high, and that leads to the urinary pregnant will be high. This is the number one. Second talk, because of 17-hydroxyprogesterone is high, it does mean the cortisol is not producing. So yes, the cortisol level will be low, aldosterone level will be low. So cortisol level low leads to the raised ACTH, aldosterone level low leads to the renin ACTH, renin increased. Yes, my dear doctor. So once again, this is the lab findings that we need to remember. So here you see the cortisol and aldosterone. These two important things that also we need to remember. We can remember very, very well. But the single talk, once again, the cup, congenital adrenal hyperplasia, means the cup, means the UP for urinary pregnant. So starting for the first box, yes, the summary talk that we have discussed here, there is up, should be remembered. Now comes up with the second important box here. I put the amenorrhea. You see the different causes of amenorrhea. So amenorrhea, of course, the pregnancy is the first. Everybody knows about them, pregnancy. Next is the ovary, primary ovarian failure. Right? Next point you see that the pituitary and prolactinoma. You see the pituitary and prolactinoma. And then you see the celiac disease, must remember, my dear. Celiac disease, weight loss, anorexia nervosa, and increased stress. Another bundle pack. And the third and most important bundle pack that we need to remember, this is the CAH bundle pack. That is a congenital adrenal hyperplasia, and androgen secreting adrenal tumor, SART, Cushing syndrome, and precocious. So yes, this is SART and SART, and this is Cushing syndrome and precocious. So these are the three important bundle packs next to the pregnancy that we need to remember causing of amenorrhea. So what I'm saying, the amenorrhea, you see the P bundle pack pregnancy, you see the primary ovarian failure. So this is nothing but the P's. Yes. Then you see the C, second talk, C for CD bundle pack means a celiac disease, weight loss, anorexia nervosa, and also excessive stress. And C bundle pack, once again, C stands for the congenital adrenal hyperplasia. Here once again SR and SR, and precocious and CS. So what I'm saying once again, this is not the amenorrhea, it is nothing but the PC. We need to remember. Next to the, you see the third box. I'm putting the amenorrhea and Hirsutism and Virilisation. My dear, listen very carefully. Amenorrhea, Hirsutism and Virilisation, you see, I have put the SS box here. You see that the amenorrhea, Hirsutism and Virilisation in case of female, the congenital adrenal hyperplasia, the clinical features, they comes up with the primary amenorrhea and Hirsutism, virilisation. That's why we need to know the other important differential diagnosis of, yes, once again, that is the amenorrhea and Hirsutism and virilisation. So yes, Hirsutism and virilisation, you see that the cause is the bundle pack, the C bundle pack we know about. After the C is a D, all right, CH, precocious, SR and SR, and precocious and CS. So here the Hirsutism, virilisation, once again, congenital adrenal hyperplasia. Next to them is the precocious. You must remember SR and SR and Cushing syndrome. The last one, and some of the drugs like, we know the minoxidil dioxide, phenytoin, cyclosporin, and some of the androgens that are abused. And number 4, yes, the congenital adrenal hyperplasia is caused by 21 and also the 11 and also 17. 11 is in hypertension. Just to remember, in contrast, 21 can be hypertension. Number 5. Number 5 important box, right? The congenital adrenal hyperplasia. I say the cup, yes, means the congenital adrenal hyperplasia. UP4, yes, once again, urinary pregnantial. Next is the clinical features. You see that the infancy, vomiting and failure to thrive, you don't need to know. But they have the ambiguous genitals, males, hypospadias, female fusion of labia, all right. But yes, the precocious puberty for case of male, but we need to remember these bundle pack only. AHV, yes. So I'm saying the AHV, amenorrhea, Hirsutism, virilisation. So the single talk here. All right. So this is the C and this is D, CD, all right. So this is the AHV. And now, this is the number 6 box. This is the number 7 box, congenital adrenal hyperplasia. See the Hirsutism before the menarche is one of the diagnostic points that we need to remember. Number 8 important point is this box, the treatment. The dose is adequate dose that can suppress the ACTH miter. This is very important because ACTH is high. So the dose is very close to the Addison's disease. So of course the hydrocortisone replacement. And the adequate response is also once again the up, means the urinary pregnant endometrial to the upper third of the normal that's suppressing. And also aldosterone deficiency is evidenced by the raised renin level and also the postural drop, and that should be given by the fludrocortisone. So hydrocortisone and fludrocortisone is a replacement of the treatment. I'd like to give another important boxes that will be really helpful. Let's write them. The very small boxes that will be differentiating of congenital adrenal hyperplasia and versus assault. So in congenital adrenal hyperplasia, of course, cortisol level will be low and dihydroepiandrosterone will be high. In contrast, adenoblastoma, like the androgen secreting ovarian tumor, that will not be happen. So this is one of the box to differentiate. Another box like congenital adrenal hyperplasia, androgen secreting adrenal tumor. If we do the low dose DST, dexamethasone suppression test, that in case of congenital adrenal hyperplasia like urinary pregnantorial, that will be suppressed. In contrast, that will not be happening in androgen secreting adrenal tumor. So this is the another box, and already we have seen the low dose dexamethasone. It does the adenocortisone that can suppress the urinary pregnantorial. So that will also differentiating points. Another differentiating points for congenital adrenal hyperplasia from PCOS. In congenital adrenal hyperplasia, the cortisol will be low and ACTH will be high. In contrast, in PCOS, cortisol will be high and ACTH will be high. So not the PCOS, just write it down. There is the Cushing syndrome caused by Cushing disease. Another differentiating points like the congenital adrenal hyperplasia and PCOS. What is that? Of course, 17-hop will be high and dihydroepiandrosterone will be high. In contrast, that will not be happening in PCOS. And also there is a short synarctin test. Short synarctin test that will be low response.
The best and the best and the best course ever you will experience in your whole lifetime.
In contrast, the normal response in PCOS. Now I'd like to talk a little bit further, so my dear doctors, so that you can understand very, very well. Just follow me. This is very easy, all right? So next to the number 8 box, the 9 important box, the 10 important box, 11 important box, and 12 important box. So what is that? Congenital adrenal hyperplasia, once again the cortisol low, but dihydroepiandrosterone also increased. In contrast, a short androgen secreting ovarian tumor, that will not be happen. Congenital adrenal hyperplasia and androgen secreting adrenal tumor. This is very important here. So yes, the low dose DST test, you see the low dose DST test, urinary pregnantorial will be low, but in contrast, the androgen secreting adrenal tumor, that will be not be happened. Now the 11 number congenital adrenal hyperplasia and Cushing syndrome, very important by the Cushing disease. Cushing disease ACTH from the pituitary that causing the cortisol level will be high. But in contrast, you see the cortisol level will be reduced and ACTH level will be high. That happens in congenital adrenal hyperplasia. Means in both cases ACTH level high, but you see the cortisol level low and increased. Next is the congenital adrenal hyperplasia PCOS. Of course, the hope and also the dihydroepiandrosterone increased, but PCOS is never happened. And also the short synarctin test is a low response in a congenital adrenal hyperplasia because they have the low cortisol. Yes, in contrast, in PCOS, there will be normal response. Yes, my dear doctor, I'd like to summarize a little bit further. So starting with the first box, we need to remember the first talk is the 17-hydroxyprogesterone, means the HOP. Yes. If I say the summary talk is the up, HOP and up, that's enough to remember. And C, cortisol, and aldosterone. So the first box, HOP and up, 17-hydroxyprogesterone, and up for urinary pregnanatrial. Second box, amenorrhea, is a PC, P for P bundle pack pregnancy. Next to the pregnancy, of course, the prolactinoma and hypopituitarism, and primary ovarian failure, pituitary and ovary. And C for CD bundle pack, and C for CAH bundle pack. CD means here the celiac disease, weight loss, anorexia nervosa, and stress excess. And congenital adrenal hyperplasia, once again, CAH, adrenal, so androgens secreting adrenal, SRT, and also the precocious and CS. Next to the Hirsutism and Virilization, once again, the box that we need to remember, of course, the single talk, there is a C bundle pack, with the congenital adrenal hyperplasia, is differential. Here is a precocious here, and CS and SR and SR, and also some of the drugs like the minoxidil, diazoxide, MD, PC, phenytoin, cyclosporine, as well as the androgens. Another box of the congenital hyperplasia 21, differentiated from the 11. 11 is nothing but hypertension. 11 is hypertension, H. You can put it H. Hypertension, in contrast, there 21, hypertension. The next talk, the congenital adrenal hyperplasia, might remember, the single talk is an up. CAH is an up. Cup. I say the cup. You see the cup? Congenital adrenal hyperplasia clinical features, of course, the AHV, Amenorrhea, Hirsutism and Virilization bundle pack. Once again, the Hirsutism before the menarche. If I'm saying the AHM, it is nothing but congenital adrenal hyperplasia. Once again. Next, congenital adrenal hyperplasia treatment is nothing but the hydrocortisone and fluorocortisone replacement. Hydrocortisone very close to the Addison's disease, but once again, that should suppress the ACTH, that is the dose, and also the adequate response is also measured by up, once again, urinary pregnanatrial. Aldosterone deficiency, of course, measured by the postural hypertension, and also the renin level is high. So once again, that needs the fluorocortisone treatment. So hydro and fluorocortisone treatment that we need to know. From the 9, 10, 11, 12, the differentiating points from the congenital adrenal hyperplasia, SR, CS, and precocious. You see the SR is nothing but the cortisol will be low, dihydroepiandrosterone, dione will be high. That will not be having an SR. Here is a congenital hyperplasia, once again from the SR, androgen secreting adrenal tumor. So adrenal gland, how to differentiate? Yes, it is very important. That is as the low-dose dexamethasone suppression test. Yes, this is very important. From among all these, right, the differentiating points, the congenital adrenal hyperplasia differentiating from androgen secreting adrenal tumor. Hyperplasia and tumor, how to differentiate? Yes, the low-dose DST suppress the urinary pregnanatrial in case of congenital adrenal hyperplasia, not happening, of course, the SRT. That already we have seen. The treatment we do the hydrocortisone is nothing but the steroid replacement. That responding there we have seen only the up, so UP. Congenital adrenal hyperplasia and Cushing syndrome, Cushing disease, there will be high CTH and high cortisol. But in contrast, the congenital adrenal hyperplasia high CTH, but the cortisol level is low. Means the cortisol low leads to the high CTH. So yes, congenital adrenal hyperplasia and also the precocious, how to differentiate? Of course, the HOP and dihydroepiandrosterone is increased, but once again, we can do the short synaptin test. That is also, remember, short synaptin test, the precocious, the differentiating points, the normal response in precocious, but congenital adrenal hyperplasia, the lowest because it has a low cortisol. My dear doctor, congenital adrenal hyperplasia. If I'm saying the summary talk, my dear, starting here, the up, the single one talk, second talk is Amenorrhea is a PC, Hirsutism, Virilism is nothing, a C bundle pack, and congenital adrenal hyperplasia 11 is an hypertension. Congenital adrenal hyperplasia is nothing but a cup. Remember, you know, pregnanatrial. Congenital adrenal hyperplasia is a AHV, Amenorrhea, Hirsutism, Virilism. Congenital adrenal hyperplasia treatment, hydrocortisone, fluorocortisone, And lastly, the differentiating features, once again, yes, congenital adrenal hyperplasia, androgen secreting adrenal tumor. Yes, you need to remember once again that the LD-DST up will be reduced, means the suppressed, and also once again congenital adrenal hyperplasia and precocious differentiating points, short synaptic test is the low responding in case of congenital adrenal hyperplasia. I hope that, my dear, the total discussion starting from the congenital adrenal hyperplasia, beforehand that the cortisol synthesis and biosynthetic process of different adrenal hormones, and their discussions and some of the differentiating points in the different important disorders. Very, very hot topic for exams, my dear. I hope that these discussions will be very effective for exams as well as in clinical practice. My dear, I hope that you enjoyed. Thank you very much. Thank you once again.